Hello, welcome back to my patient education on the topic of total knee replacement site. This is a new video, and we're going to focus on the timing of surgery. This pairs with the book I've written, as described in my previous sessions, A Proactive Approach to Total Knee Replacement. I'm Dr. D.Graybill, MD. I've written this book, published in October of 2025 on the e-version. It's available on Kindle, Apple, Barnes & Noble, and published by BookBaby. And the purpose of really the video site is to kind of supplement the book, give people access to some topics in a little bit different fashion than reading, although we're not going to cover by any means everything in the book. I hope that you can find this beneficial and entertaining. One of the questions that is very common in my practice is, when should a patient consider knee replacement? What's the proper timing? So basically, obviously we don't want to do it too soon, we don't want to do it too late, and we're going to discuss a pathway for patients to make that decision. And in the vast majority of situations, patients drive that decision, not their surgeon. The surgeon can recommend at a certain time, but mostly it's patient factors that drive the timing of surgery, and we'll discuss a few exceptions to that towards the end of this talk. So moving onwards, there are objective factors. A patient can't just walk into a surgeon's office and say, I want a total knee replacement, without a demonstrated reason for it. So from the surgeon's aspect, the feedback that patients need to have is they have quite significant disease on imaging. Imaging is almost always a standing knee x-ray series where we would see advanced narrowing of the joint space or complete narrowing of the joint space in combination with symptoms that limit activities. So that's, in a brief summary, the objective things that a surgeon should want as criteria prior to considering knee replacement. So if someone comes in and wants a knee replacement and their x-rays are close to normal, that usually isn't appropriate. There are a few things that aren't picked up on x-rays. So if a patient has a high level of symptoms in that situation, occasionally something like an MRI might be chosen, which is not the typical imaging choice to qualify for knee replacement, but there are some problems that are not identified in x-ray, like avascular necrosis or a severe focal disease, which might not be picked up on imaging, where a patient still might qualify. But in general, substantial x-ray evidence of arthritis and substantial symptoms are appropriate. The timing of the symptoms also is important. If a patient presents and they only have pain at rest, no pain with or after activity, that's kind of a warning sign, because those types of symptoms, if they're the majority of the symptom isn't when you're doing things, there are other things that cause knee pain besides arthritis. And obviously, if we do a knee replacement and your pain is coming from something besides your knee, it may not get better, probably won't get better. So that's the objective side. So on the subjective side, this subjective means what the patient feels. So here is where we really get the majority of patients drive their choice to knee replacement based upon how bad they feel, how much pain they have, and how much limitations they have. So we do have some patients that don't have severe pain, but they will have lots of activity. Activity limits. They can't climb stairs. They can't walk very far. They can't do the things that they need to do to function. If they have advanced arthritis and have those limitations, surgery may very well be appropriate. The same thing can be true with a patient who still can walk a lot and remain moderately active, but they're miserable because they hurt after they walk or during their walk, or they hurt more the farther they walk. They might have a high pain tolerance and still perform those activities, but that patient also probably qualifies for knee replacement on a symptom level, again, presuming they have x-ray and other criteria. So the majority of the time when a patient would present to me with advanced arthritis on x-ray, I would talk to them about treatment options from non-surgical through surgical. And if they were not having a lot of pain yet and still were pretty active, even though their arthritis might be severe, it might be very reasonable to wait. On the other hand, as we spoke in the last video about activity level, if they start to struggle to maintain good physical activity, good exercise level, if their capacity starts to decrease, I really am careful about that patient and kind of steer them towards surgery. If your physical capacity is diminishing and you have significant arthritis, despite medical treatment, you should strongly consider surgery, in my opinion. So let's move onwards. Again, re-emphasizing, my opinion, most important trigger for surgery is a patient that can't maintain at least a moderate level of activity. Despite medical management, this is when surgery probably is the right time for most patients, assuming they're medically healthy. There's a few patients that have enough medical complexity or problems that they aren't great surgical candidates. This is infrequent. Some medical situations are certainly improvable. There's a nice discussion of optimization in the book. We'll go over a little bit of that in some subsequent videos in a scattered fashion, but many medical situations are improvable, and most patients are indeed surgical candidates. So going beyond the patient wanting surgery, there are patients that are either don't want surgery, afraid of surgery, trying to wait as long as possible. Maybe they still can maintain pretty good activity levels. I've had many experiences with patients in this situation, yet they are doing damage to themselves. So to do surgery well, we need certain criteria on the surgical side. So a knee replacement resurfaces the bone. Obviously, if we have too much bone loss, we don't have our normal bone platform for surgery. This creates a problem for your surgeon where they might need to do a larger operation, which isn't as reliable and sacrifices some future options. In that situation, if I've got someone who's wearing down more than a few millimeter bone where the bone loss is becoming significant, I will push that patient towards surgery. The same thing is true with ligaments. A number of the ligaments are replaced during surgery, so an ACL tear and typically a PCL tear, as long as the anterior posterior instability isn't too great, can be nicely accommodated, but the medial collateral ligament, the one on the inside of the knee, cannot. So if we have a knee that, when is unweighted, is very floppy, maybe goes past straight, can be angled 10 degrees in both directions or more. That's something that, again, has some surgical remedies, but they become more complex, not quite as reliable, and we really would want to have the patient undergo surgery before that moves along too far. Another example might be severe loss of motion. If your knee can't get even close to straight or can't bend very well, a knee replacement in that situation is unlikely to get outstanding range of motion. It can be improved, but isn't optimal. So that might be another reason to move towards surgery earlier than a patient might desire. And our job as surgeons is to kind of guide the patients in these situations. I mean, in most situations, 85, 90% of the time, I would let patients kind of guide themselves with my recommendations. And then maybe 10% of the time, or a little more often, patients present with either x-ray bone loss, this ligament issue, or severe loss of motion, where I tell them, well, surgery may not be emergent, we don't have to do it next week, but really you should be moving towards this over the next few months, or our outcomes are going to be further compromised. And again, that's a discussion with your individual surgeon, but there are reasons that surgeons kind of push patients towards knee replacement very appropriately. So again, that kind of ends this talk. For additional discussions or details or other non-surgical options, please look to my book, Proactive Approach to Knee Replacement, a data-driven guide to reduce complications and increase the odds of an optimal outcome. I really hope that patients pursue this. I think education is important and can lead to better outcomes for anyone considering a knee replacement. So I hope you enjoyed the talk. We'll move on to more topics gradually over the next few weeks. And even subsequent to that, I may have some talks come up based upon any other feedback I get from my physician friends or patients. So thanks again. Have a great day.